Welcome to the AETCM Emergency Medicine channel. So main things what we need to learn is that we should not do any harm to the patient. That will be our priority. So what are the correct things that we need to do to a victim who had a accident on the scene? So the basic management starts from the scene, that is you need to stabilize the patient in the scene and you need to transport the patient properly in an ambulance or whatever vehicle is available to the hospital. So that is the primary aim of an emergency medical technician. So you have learned a lot regarding emergency medical technician. As you are aware, the primary treatment starts from the scene, that is taking the patient from the accident site to the hospital. So the transport is a major part which is handled by the emergency medical technicians primarily, because as you know, our pre-hospital trauma setup is not that great. Our country is trying to change on it. So what we are trying to do is that what are right things that we should learn and also we should teach to our colleagues whenever a trauma victim is being transferred from the site then to the hospital, inside the ambulance in between, and once the patient reaches the hospital, what should be your priorities in managing a patient. So what we will call it as is the advanced trauma life support, otherwise I will be mentioning it as ATLS, advanced trauma life support. This is basically a terminology, basically a system of patient management developed by the American College of Surgeons, and every 5 years they update on this and they have come up with certain guidelines for the management of a trauma victim. So what does the ATLS teach? ATLS teaches, they have studied the group of patients who had RTA and they have found out that there is 3 peaking times where a patient will die following a trauma. That is the initial phase that usually happens within seconds to minutes. That is the first peaking. So what we will call as trinodal death pattern. In the first peaking is within seconds to minute, and the second time where the patient die is from minute to hours, and the third phase is within hours and days. That usually takes days. So the initial thing within seconds and minutes will be very difficult to save the life of the patient, but the second peaking, that is within minutes to hour, we have got some golden hour of trauma where we intervene properly, where we do the right things on the right time, we can save the patient. And the third peaking usually happens due to infection following the trauma. So what the ATLS does here is to prevent the second peaking and to stop the death due to the second peaking of death in a patient having a trauma. So that is what we are going to learn. So as soon as I told, initially you need to go to the patient, and there can be different category of patient that will be learning in our hands-on training. There will be different group of patients. Some patient will be responding, some patient will not be responding. So we need to tackle each group of patients so that we learn on the bedside or on the stations that you are going to see. And the next thing what we need to remember is, once the patient has reached the hospital, we have divided the initial management into 2 aspects. That is the primary evaluation and secondary evaluation, or you can call it as primary assessment or secondary assessment. So the primary assessment basically starts with your management of your A, B, C, D, and I will be elaborating on each one of this. And after the primary assessment, there is something called as adjuncts to the primary survey. So what are the things that you need to additionally do? Some investigation, which are the basic investigation that you need to do, and followed by a secondary assessment, basically starts with a brief history, that is what we call as sample history, followed by an head-to-toe examination. So first let's see what do you mean by a primary survey. So as soon as the patient reaches the hospital, somebody has safely transported the victim and the patient is in front of you, you need to start assessing with the airway. So airway means it is the passage of the air from the nostril to the lungs. So the airway has to be kept patent. So to make a patient stable, the first thing that we need to look is to make sure that his airway is patent and it is clear. So there are a lot of maneuvers by which you can make it stable. So the main thing that you need to look is the airway, and A also stands for cervical spine immobilization. So whenever a victim is coming with a trauma, the first thing that you need to remember that you have to stabilize the airway, followed by cervical spine immobilization. There are different ways by which you can do the cervical immobilization. The most important thing that you need to take care is that A stands for airway with cervical spine immobilization. Assessment of airway we will learn in the station. So airway with cervical spine stabilization, that is the first thing. And how to do cervical spine immobilization, there are different methods. We have got manual inline stabilization, we have got cervical collars. When you don't have anything, you can use sandbags or whatever is available. Without shaking the head, the patient should be mobilized to the hospital, or once the patient reaches the hospital, while you are transferring for an X-ray or a CT, all those things you need to take care of the cervical spine. That we will learn in our bedside stations. So first thing that you need to remember, that A stands for airway with cervical spine stabilization. The next important thing is regarding B. B holds for breathing with oxygenation. So you have to assess the breathing pattern of the patient. So what are the things, key points that you need to look for a breathing pattern? One is the type of respiration, whether it is abdominothoracic, or there is any flail chest, that is one part of the chest is moving and other part of the chest is not moving. So there is some paradox in the movement of the chest wall. So usually in flail chest you get something called as paradoxical respiration. So you have to see whether there is any paradox. And the next most important thing is that you need to see is whether the respiratory rate. What is the respiratory rate? Usually due to the pain or due to respiratory insufficiency secondary to trauma or a hemothorax, the patient can be tachypneic initially, followed by bradypnea, then the patient going to respiratory failure. And the next most important thing that you need to look is the SpO2, that is the oxygen saturation in the blood. So the most important thing in B is breathing. So once you assess the breathing, also you need to auscultate the lung field to look for any evidence of pneumothorax or hemothorax. So how will you evaluate that? You need to look for your air entry. If air entry is absent on one side and you have a percussion, you have to percuss the lung, and you can decide whether it is a pneumothorax or a hemothorax. If there is an associated hypotension, there is distended neck veins, and with the absence of air entry, we will call it as tension pneumothorax. That we will learn when you come to the bedside. So you have to make sure that the breathing is fine. Also you need to start the patient on a supplemental oxygen. So B stands for breathing with oxygenation. So what are the major things that you need to remember is that oxygenation is also a key part, just not assessing the breathing, and you need to start the supplemental oxygen. The ideal thing that you can start is something called as a non-rebreathing mask. You can start with 12 liters per minute oxygen through a non-rebreathing mask, so that the fraction of inspired oxygen what patient can get is nearing to 80 to 100%. So that is the best way by which initially you can start with, and later on, depending upon the oxygen saturation, you can come down on the oxygen delivery devices. But the best thing will be to start with an NRBM to give to 12 liters per minute through something called as a non-rebreathing mask. So that is the assessment of breathing with circulation. Now we have done A and B. Now we will go to C. C is basically the assessment of circulation with hemorrhage control. We need to have the control of the hemorrhage also, and you need to assess the circulation also. So how will you assess the circulation? It is very straightforward thing. The most important thing is that the patient can have hypotension. So prior to hypotension developing, there can be certain signs by which you can say the patient is going for hypotension, and you need to find out how the circulatory status is. The most important thing, starting one, is the heart rate. Usually the patient will have tachycardia, but the initial phases of hypotension, there are different classification of shock. The initial classification of shock, the patient might not have tachycardia. And the next thing is that you have to look for the blood pressure. So what will happen usually to the blood pressure? If the patient start developing hypotension, the blood pressure will be low. So the blood pressure and the heart rate are the first tools, and also you can look for the something called as the capillary refilling time. You can just press over the thumb or over the toes, and you just see how much time it is taking to refill. Usually it should be less than 2 seconds. If it is more than 2 seconds, that means the patient is having a circulatory issue. So now coming to the assessment, as I told, you have to look for the blood pressure, and you have to look for the heart rate, and you need to look for the capillary refilling time also. And also the most important thing is that you need to control the hemorrhage also. The hemorrhage has to be controlled. So that is the next key point. So usually what is the main reason for hypotension in a trauma is an hemorrhage. Unless and until it is proven, you have to take it as it is hemorrhage. So where all the patient can bleed usually? One is externally. There is a large wound and patient is bleeding from that. You will be able to see that, and you can give some compressions, and you can maybe apply some pressure bandages, and you can stop the bleeding. So that is the first thing. The bleeding can be an external, or the patient can bleed into the chest, so where we can have hemothorax, or the patient can bleed into the abdomen, where you have a positive focus assessment sonography in trauma, which I will discuss in the adjuncts to the primary survey. And the next thing, the patient can bleed into the pelvis. Usually the pelvic can accommodate nearing 1 to 1.5 liters of blood, and the patient can bleed into the thighs also. So these are the important things that you need to assess. One is that you need to do the circulatory assessment. As I told, the hemorrhage is classified, hemorrhagic shock is classified into 4: class 1, class 2, class 3 and class 4. And in class 1 and class 2 hemorrhagic shock, there will not be any hypotension, and class 3 and class 4 hemorrhages, the patient will be having hypotension. So you need to start the patient on an IV fluids. To start on IV fluid, before that what we need to have? We need to have a minimum of 2 large bore IV access. So what is a large bore IV access? Any cannula size that is less than 18 gauge. So as the number decreases, the cannula diameter increases, the length also decreases, so the flow rate will be more. So any cannula less than 18 gauge, you should be putting minimum 2 numbers, and either you need to start ringer lactate or normal saline. If the patient is having hypotension, you start with a fluid bolus of approximately 1 liter. So you don't want to overtreat the hypotension also, because what will happen usually when you have an hypotension, for example the BP is 80/40 and you started correcting with your IV fluid, now the BP has become 160. So we'll think that the normal BP is over 120/80, we want to increase to 120/80, but we should not be doing that. This is called as permissive hypotension. You need to remember that what will happen when you increase the BP to 120/60, 120/80? Again the blood flow will increase. So whatever thrombus has happened, whatever clot formation has happened, it will get dislodged again, and again there is a chance of rebleeding by the dislodgement of the clot. Normally our body will to try to form a clot wherever there is a bleeding. So when the blood pressure is increasing rapidly, what will happen? The clot will get dislodged and further bleeding will occur. So that is what strategy we will use, that is called as permissive hypotension, hypotensive resuscitation. These are all terminologies used for the same: permissive hypotension, hypotensive resuscitation, or otherwise it is called as balanced resuscitation. So you should have a balance, equal balance. We need not over treat the hypotension. So we should be able to maintain a blood pressure in order to maintain an organ perfusion. So maybe our target should be somewhere around 90/60 or 160. We are happy with it. We need not over correct the hypotension. So that is the most important thing. But remember that if the patient is having an isolated head injury, so if the isolated head injury is there, we need to target a higher BP, because what will happen if the BP is low, further the cerebral perfusion will be affected if the patient has got an isolated head injury. Otherwise, if there is only an hemothorax, you can have an 100/60 is acceptable BP. But if the patient is having an isolated head injury, or a head injury is very severe head injury, you need to, and increasing the blood pressure, then only the cerebral perfusion pressure will be maintained. So you need to remember that the most important thing in assessment is, first we have discussed regarding the airway management. You have to make sure that the airway is patent, and if the airway is not patent, we need to do the maneuvers like suctioning, we need to give supplemental oxygen, all those things. That is the first thing. Airway, breathing assessment, you start on an NRBM, and circulation, the most important thing is that you assess the patient and you start the patient on 2 large bore IV access. If there is hypotension, you start them on 1 liter normal saline or ringer lactate. So that is the initial fluid of choice, and meanwhile you arrange for the blood. Depending upon the initial fluid response, we have given the fluid to the patient. Depending upon how the patient respond to your fluid therapy, we have divided the patients into 3 categories. One is rapid responders. You are given the IV fluid, their BP is back to normal, we are happy. The second group is transient responders. We have given the fluid, but the BP has transiently increased, but again it is becoming hypotension. And third group is non-responders. Whatever fluids you are giving, the BP is not improving, it's still the patient is having hypotension. So the rapid responders, fine, we are happy. And non-responders also, we will go to the next step, that is transfusion of the blood, or maybe we will be shifting the patient to the theatre for the definitive management of the bleeding source. But the transient responders is the group of patients that we can miss, because initially you have got like 5-6 RTs have come and you have stabilized the patient, and you have seen that the BP is okay, now it is 160, you are happy, we have gone back, and suddenly when you are coming back the BP is only 80/40. So that is the group of patients that is transient responders. So those group of transient responders, you need to be more cautious, and you should be spending more time with this group of patients, because they can be a non-responders, and maybe a primary treatment will be shifting to the theatre for the management. The next thing that we have to discuss is the disability assessment, D. Disability assessment, the most important thing is something called as Glasgow Coma Scale. We know that there are three components for a Glasgow Coma Scale, that is eye response, verbal response, and you have to ask for the motor response. So see, these are the three components. Depending upon that, we need to assess the patient, and we will call it as mild, moderate or severe head injury, depending upon the assessment of by doing our Glasgow Coma Scale. And always remember to perform a glucose random blood sugar, because hypoglycemia may be mimicking inside a trauma patient. So don't miss that. Always ask for an GRBS also. And finally, coming to the exposure, that is because we are giving a lot of fluids to this group of patients. Usually the fluids will be very low temperature, so there can be chance of hypothermia. Also, the patient is not adequately exposed, because we would have been examining the patient, we will be removing all the clothes. So you have to prevent hypothermia, because hypothermia is the another risk factor that can push the patient into DIC. So DIC is disseminated intravascular coagulation. So exposure you need to prevent from hypothermia. So that concludes the primary survey. So primary survey basically does is the assessment of the airway, breathing, circulation, disability and the exposure. What I've told is a vertical approach, but what we usually does is an horizontal approach. There will be more than 2 or 3 people around the patient, so simultaneously one person will be assessing the airway, other will be assessing the breathing. If the breathing is not fine, they will go ahead and intubate the patient, or oxygenation is not adequate. We will all, these things are done simultaneously, but for teaching purpose we have listed it as in a vertical order, that is airway, breathing, circulation and disability and exposure assessment. So that concludes the primary assessments. Once you are done to the primary assessment, there are certain adjuncts, that is add-on things that you need to do to the primary survey. The important adjuncts that you need to remember, you need to ask sometimes for an acid blood gas, that is your ABG. You need to ask for an ABG. You need to ask, sometimes you need to put a Foley's catheter to the patient, maybe a Ryle's tube insertion. And the most important investigation that you need to remember is an focused assessment sonography in trauma. So that is, I will not say it as an adjunct, it should be actually, it is a part of our primary survey. All trauma victims should undergo a focused assessment sonography in trauma. Basically, what do you mean by a FAST? We are getting an ultrasound mission, and 4 areas we are looking for any fluid collection: hepatorenal pouch, splenorenal pouch. In the epigastrium we are looking for any evidence of cardiac tamponine, and around the bladder we are looking any evidence of free fluid. If any evidence of free fluid is there, we will call it as FAST is positive. If the FAST is negative, that means the first FAST is negative, but if the patient develop hypotension, I will get back my ultrasound mission and I will repeat the FAST. So the initially it can be negative, but later on it can be positive. But if the FAST is positive, that means there is a free fluid inside the abdomen and there is some internal bleeding is there, and you need to tackle that. So you need to get your surgeon in immediately and you need to tackle that. Maybe another investigation depending upon the patient's hemodynamic status, we need to plan. Maybe a CT abdomen we need to continue, or a CT chest, depending upon the scenario we need to decide. So the next most priority, what I will say, is the focused assessment sonography in trauma. And always remember, when you go from one step to the other step, you always reassess your vitals. So you go back to the patient, you see how are the vitals of the patient, what is the heart rate, what is the blood pressure, what is the saturation. Because what we'll do all this investigation and we'll be finishing some 10-15 minutes by the time the patient would have worsened. So that should not happen. Whenever you are finishing from one step going to the other step, always remember you reassess the patient. So once we have done our primary assessment, we have add-on such adjuncts to the primary survey, and if needed you can go for a chest x-ray, AP view, and an x-ray pelvis. Previously we used to do a cervical spine x-ray, but nowadays we are not mentioning cervical spine x-ray as an initial adjunct to the primary survey. Now the patient, we have stabilized the patient. Remember, you have stabilized the patient. Now the next step is you going for a secondary survey. So secondary survey basically start with a sample history. Sample history stands for S for what are the signs and symptoms why with the patients has been brought. Obviously there was a history of accident, what is the mechanism of injury, all those stuffs you can ask. M stands for what are the medications the patient is taking. P for the past medical history, or in a female patient pregnancy. L for when was the last meal taken. This is the most important thing. E is the event, what got the patient here. Most important thing is that you need to ask for your, most importantly, the mechanism of the injury, how the patient has brought. And A, which I missed initially, it is the allergies. Obviously we need to ask for any allergies. If the patient is not able to answer, you can check your system, or maybe you can ask his friends that whether the patient has any major allergy to any drugs. So S for the signs and symptoms, A for your allergies, M for your medications, P for your past medical history, pregnancy in a female patient, L for the last mean and E events. What got the patient into the emergency room, how was he brought in, what was the mechanism of injury, whether he was thrown out of the car, because all this information is very important, because with knowing this information only we will be able to proceed further. So once you are done your sample history, next thing is called as head to toe examination. You need to start examining the patient from your head till the toe, that is each and every system in detail you need to examine, and depending upon your positive findings you need to ask for a further investigation. Maybe you need a CT head, maybe your other x-rays, maybe an extremities x-ray. These are all only our secondary priority. So what does an ATLS primary look into? First we have to identify, stabilize any life threatening injuries, then followed by any limb threatening injury. So priority is our to save the life of the patient. That's what I told initially. We need to prevent the trinodal death peaking, and in the second peaking is that what is we are targeting, and we need to prevent this. So the second peaking is our target. So always remember that all the other things can wait. The priority is your airway with your cervical spine stabilization, breathing with oxygenation, circulation with hemorrhage control, and disability assessment, your GCS and your glucose random blood sugar, and preventing hypothermia by doing adequate exposure. So these are the things that you need to remember. Now what will be the next step is that you need to know how will you assess. So that we will learn in the coming session. Thank you for watching.